So thank you, Representative Sweetbox, and to the Indian American Impact community for inviting me to the Core Summit, Desis Decide. It's truly an honor for me to be among all of these advocates and change makers of the South Asian community to speak about the health of U.S. South Asians. So many of us in this room have lost a family member to heart disease. Growing up as a first generation Indian American, I remember the phone call from India telling us that my grandfather had died of a heart attack at the age of debriefed. But we weren't alone in our close-knit South Asian community. It seemed like everywhere there were stories of people losing parents, grandparents, aunts, uncles with heart disease at a really young age and very unexpectedly. These losses and disparities are not new. Like that's the next slide. If I can have the next slide. Mike, okay. So these losses and disparities are not new. It was documented in the 1950s and 60s in earlier South Asian diaspora communities. And this is an article from 1994 that describes research showing that South Asians in Britain had a 40% higher rate of heart disease than the rest of Britain's population. But what was baffling those researchers, Indian American, I remember the phone call from India telling us that my grandfather had died of a heart attack at the age of debriefed. But we weren't alone in our close-knit South Asian community. It seemed like everywhere there were stories of people losing parents, grandparents, aunts, uncles with heart disease at a really young age and very unexpectedly. These losses and disparities are not new. Like that's the next slide. If I can have the next slide. Mike, okay. So these losses and disparities are not new. It was documented in the 1950s and 60s in earlier South Asian diaspora communities. And this is an article from 1994 that describes research showing that South Asians in Britain had a 40% higher rate of heart disease than the rest of Britain's population. But what was baffling those researchers that many of the South Asian patients didn't have the typical warning signs for heart disease, like high cholesterol, and the traditional Indian diet actually seemed healthier than a typical British diet. So I witnessed this same phenomena as a medical resident at Bellevue Hospital in New York City. I would be called down to the emergency room for a patient who was having a heart attack, and often it would be a young South Asian person in their late 30s or early 40s. And then these individuals would follow up with me in my clinic. And when I asked them what was causing their high blood pressure, what caused their heart disease, their answer would often be stress. So when I spent some time learning about my patients' lives, it became clear that the stress of immigration, working long hours, limited access to healthcare, and the loss of family support when someone immigrates, these are all stressors that lead to worse mental and physical health. Next slide. So when I began my research career to understand why this was happening, it quickly became apparent that there were large knowledge and data gaps about the health of South Asians and about other U.S. South Asian communities. In fact, Asian Americans were often being excluded from key health equity initiatives, like what we saw in the city of Chicago. And we had little data on different Asian subgroups in national surveys, local surveys, or in our health systems. And it's really important to know that what is measured is what is valued, and what is undercounted tends to be counted out. So thinking about that, I knew that the very first step to making progress on South Asian health would be to make progress towards data equity. Next slide. So with Dr. Alka Kanaya at UCSF, I established the Mediators of Atherosclerosis study in 2010. This is a longitudinal prospective cohort study, and our goal is to investigate the factors associated with heart disease and diabetes in South Asians. We wanted to create an infrastructure to better understand the biological, environmental, social, and cultural factors that contribute to this excess risk of heart disease and diabetes among South Asians. We've been following over 1,000 people for 14 years and have research sites in San Francisco, Chicago, and New York. And thanks to our community's input, we're expanding the follow now to be more inclusive and representative of all South Asians. And we're currently recruiting 1,000 more participants of Pakistani and Bangladeshi background in addition to the over 900 indigent individuals that are in the cohort. So if I get the next slide, I always tell people, because they ask me, like, what is the reason that South Asians have this high risk? But like finding that reason for IPF, heart disease risk, and diabetes, it's like a puzzle, a 1,000-piece puzzle. And there are so many pieces, and there isn't going to just be one piece that gives us that full picture. But the good news is, from the Masala and other research that's going on in the US, we're starting to put some of these pieces in place. Let me give you a really small snapshot of some of the most important things we've learned from Masala and from the research that's going on across the country. We've learned that US South Asians have among the highest rates of diabetes and high blood pressure compared to other major race and ethnic groups in the US. And this came as a major surprise to many health professionals, because just like the model minority myth, there is the assumption that South Asians don't experience health disparities. Another thing we've learned is something that's really different from what you see in other groups, is that even at a normal body weight, South Asians develop risk factors for heart disease like diabetes and high blood pressure. And why is that? That's because even at a normal body weight, South Asians tend to store excess fat in places that we can't see, like the liver, around the abdomen, around the heart. And this hidden fat puts us at risk for heart disease and for diabetes. So what does that mean for you, your friends, your family? I think it means we really need to get the message out that even if your body weight is considered normal, you should ask your physician to screen you for heart disease risk factors. We also need to make sure that we're uplifting everyone in our community to stay as physically active as possible from a young age, because both resistance exercise, aerobic exercise, works on those hidden fat stores that may not be obvious to us. Another really important piece of the puzzle is diet. Everybody wants to know, what should we eat? And for a long time, we didn't really know how to give people the correct information. We know that the food we have access to and what we eat matters for our health. And really unique data from Masala on South Asian diets has taught us that not all vegetarian diets have health benefits. In fact, in Masala, we found that many people were eating vegetarian diets, but those vegetarian diets consisted of high carbohydrates, high fat, and sugary foods. And that vegetarian pattern is associated with more insulin resistance, high blood sugar, and developing diabetes. Other people, however, in Masala were eating a vegetarian diet that was lower in salt and really high in fresh fruits and vegetables, and lentils and legumes. And that pattern has actually been associated with lower blood pressure, better cholesterol, and less liver fat. So this is the type of information we're learning that we can now use to counsel our community more effectively about prevention and healthy diet. But I don't want to just focus on the negative. We've also learned that having strong social connections and how you adapt after you immigrate to the United States, those things can be protective for your heart health. And that is so important, because too much research categorizes being South Asian as a risk factor for disease. And I just want everybody to know, being South Asian is not a risk factor. That's really important. We need to shift the conversation. There are a lot of strengths in our community, like our strong social fabric, that can protect our health moving forward. And finally, which is why I'm here today, it's really not going to be enough to publish these research findings in a medical journal. What matters now is that we get this knowledge out, we get this research out to our community. We develop prevention and treatment programs that are created with our communities, that are culturally relevant and accessible, regardless of language barriers, income, or immigration status. So as we come together today, and I'm so excited to be here with you and to have a chance to speak with all of you after this, let's commit to making sure that research on South Asian health is widely shared and will be used by our communities to create those systems and structures that are going to support health equity and well-being for all South Asians. Thank you.
Thank you so much, Dr. Kandula. Your research has really opened up the doors to so much of the stigma that has hindered cardiovascular health for so many in our community. So thank you for the work you're doing, and I'm eager to see what else you find. Our next speaker now brings us to the world of mental health. Dr. Ashwin Vasan is a physician and a primary care physician based in New York City, where he also serves as the commissioner of the New York City Department of Health and Mental Hygiene. He, in addition to that, is on the faculty at Columbia University, where he teaches at both the School of Medicine as well as the School of Public Health. He has been a major pioneer in bringing digital health and telehealth to the mental health sphere to expand service outreach, and actually set up a national policy office right here in DC to fight for improved community-based mental health services. I am eager to hear what you have to share with us, Dr. Hassan, on this incredible quest to improve mental health for everyone. Thank you.
Good morning. Come on. Good morning. We can do better. Let's do this. Come on. I'm gonna have caffeine in my blood. I'm sure you do too. I'm very glad to be here, to be back here with Impact. I was here last year with a similar group of people talking about healthcare, and it's great to see it centered in the agenda this year. So thank you to Chintan, to Neil, to Gautam, and to everyone who have really lifted up this community, our community. It's great to be here during ANHPI Awareness Month. We are truly a force to be reckoned with. We're the fastest growing population in the United States, and people can ignore us no longer. And so when we speak on issues of health, yes, we're a bunch of doctors up here talking as doctors too, but we're trying to frame these issues as deeply social and deeply political. Mental health is one of those issues where it's become a kitchen table issue, and in ways that we haven't seen in a very long time, if ever. I'm also really glad to be here during Mental Health Awareness Month. I think it's a perfect time to be talking about these issues with you at a time when, frankly, mental health is getting unprecedented attention and investment like we haven't seen in its history. And so, obviously, I play the role of New York City Health Commissioner. I'm involved in setting and executing on mental health policy and programs in the biggest city in the country. But I'm also engaged in efforts to push forward mental health policy nationally. And I have to say, this administration, the President, the Biden-Harris administration, has done more for mental health than any other administration in the history of this country. And I just want to make sure that you understand that. And I want to take a minute to really celebrate some of those wins. I know we love to kind of go down our checklist of wins, but I think it does deserve its day in the sun. Through the American Rescue Plan, the Bipartisan Safer Communities Plan, this administration has done things like expanding certified community behavioral health centers, BHCs. These are the community hubs that were always envisioned when we talked about building a community mental health system. In 1963, John F. Kennedy passed the Community Mental Health Act, which not only closed down mental health asylums, but was supposed to make corresponding investments into community mental health, psychiatry, primary care, supports, psychosocial supports. That investment never came until now. And so we are building that system every single day, and New York is benefiting from that. 988, the creation of a national mental health crisis hotline that will, over time, shift the culture so that 911 is not the first call that you go to when you've got a problem, that where you know you can get help, whether your problem is small or big, where you know you can get help for a loved one who's in crisis or needing mental health care. That is a sea change. And we're just at the beginning. We're just at the beginning of implementing that. And New York has gone long on this. In fact, one of the first things I did as commissioner was get rid of our own mental health hotline, which used to be called NYC Well, and transition over to the federal hotline because I wanted us to be an exemplar of the country of what it takes to actually do this. Mental health parity enforcement. We know the brain and the body are connected, but our insurance system doesn't pay for it that way. On average, across the country, we pay about 80 cents on the dollar for mental health care and substance use care as we do for physical health care, like heart disease that we just heard about. Think about that across trillions of transactions in our healthcare system. That's billions of dollars that's drained from our system that could be pumped back into hiring more nurses, psychiatrists, social workers, building more mental health facilities, opening up more psychiatric beds. I mean, We have to start enforcing the law, and this administration has done more than most to make that happen. And overdose prevention and our suicide prevention strategy, which was launched, the HHS suicide prevention strategy, which was recently launched. First time in our history that we're setting out measurable goals as a country for reducing suicide and overdose. That's a big step. So the president has done his part, their part, the administration. And in New York City, we're doing our part. We've set out a North Star agenda to improve health spans and lifespans in New York City, to reach our highest ever life expectancy in New York City, 83 years, by 2030, and setting out measurable goals of reducing the leading causes of death. So you can imagine mental health has a huge role to play, reducing overdoses by 25% by 2030, reducing suicides by 10% by 2030, reducing homicides and violence by 30% by 2030. So the only way to get there is by building a better mental health system, expanding access to supportive housing. We've invested $1 billion in New York State alone, and with partnership from the governor. About $500 million of that is in New York City. We've doubled our funding to build up psychosocial rehabilitation centers. We've launched NYC Teen Space, a digital mental health app available to over 400,000 New York City teens for free, age 13 to 17. We've expanded school-based mental health centers. We've declared social media a public health crisis and launched a lawsuit against TikTok, Snapchat, YouTube, and Meta to hold them accountable for their mental health impacts. Okay, great. So I've gone through a laundry list of policy wins. How many of you are just excited to run out the door and become mental health advocates based on that? No, right? It doesn't land in the same way. Because mental health, of all the issues we talked about, is deeply, deeply human. And our community, I'm going to speak some truth to you all, because this also comes from a very personal place. We don't do a very good job on this, and we have to do better. We are no different than anyone else in that sense. About 1 out of 5 of us report that we have had or will develop a mental health condition across our lifetimes. But we have one of the lowest rates of treatment engagement amongst any group. Not only lowest amongst AA and HPIs, but lowest amongst, certainly lower than white Americans, about half the treatment engagement compared to white Americans. We experience disproportionate stigma, discrimination against people with mental illness. We structurally treat people with mental illness in our communities poorly. Our examples come mostly from our countries of origin, which have criminalized, which have other people with mental health conditions in such a way that make them pariahs in society. We are not unique, but we are here amongst ourselves, and we have to do something about it. We also don't have the language of mental health often in our native tongues and in our cultures. The language of mental health is not only highly medicalized, it's highly Western. And so if we can't adopt the language of depression, anxiety, and trauma, and so forth, then we need to figure out ways to talk about it in our own languages and in our own ways that resonate intergenerationally. If we can't, then we better get on board and start using the terminology that is in our country here. You know, I want to end by talking about 2 things that I see across the work that I do in our community, and I see it in my own family, and that's shame, and trauma. I think we are a community that holds on to a lot of shame. Shame because we didn't go to the right schools, or didn't get the degree, or became an elected official and we should have been an infectious disease doctor, or we hold on to a lot because we're always feeling like we're disappointing someone, disappointing our parents, disappointing our forebears, disappointing the people who took a bet on us, who paid for school. And we're also not talking about trauma. So let me tell you 2 skits. My uncle committed suicide when he was 10 years old. when I was 10 years old, I'm sorry. I didn't actually learn he had done that until I was about 35. My parents did that so deep, they told me he died of a heart attack infections. And I didn't learn that until 25 years later. Such was the shame that my family felt. Can't talk about it, gotta bury that, didn't happen, I'll make up another reason. I'm sure it came from a good place of not wanting to hurt anybody else, but also not wanting to bring shame upon my family and our culture. Let me also talk about trauma. I talked to my dad recently in a very vulnerable moment. He's 86. And he said to me, or I said to him, I said, Dad, sometimes when we're talking and we're having conflict, you tend to pull away. You tend to go off, you get on your iPad and start reading. And I said to him, why do you do that? Like, we kind of need you to be engaged in your conversation. And he said, he's never said this to me before. So thank you for he said, oh, my dad did that. My dad did that. By the time my dad was 15 years old, his father had lost 2 children. My dad's older sister to polio, and my dad's younger brother to drowning in India. And once that happened, my grandfather, who I didn't actually know, who passed before I was born, just retreated into the shadows. He just stopped engaging. And so my dad saw that, and our children follow us. Our children follow our lead and what we're modeling. And he just stopped engaging. He stopped engaging. So our parents carry that trauma, and they pass it on to us. So when people talk about intergenerational trauma, it's a real thing. We better start talking about it and dealing with it. So what can you do about it? What can you do about it? I'm going to leave you with 4 things. Okay. Number 1, you have to love yourself. You're good enough. You've done enough. You're fine. There isn't one more thing you can do to make yourself better or to prove yourself to someone else or your parents or anyone else. You are what you are, and you're great. I'm trying to pass that message on to my kids. You're great. You're great the way you are. There's nothing to prove. And unless you can do that, you're of no use to anyone else trying to help them. You have to start with yourself. Number 2, take care of yourself. Physical and mental health are connected. What we eat, what we drink, how we move, that all matters a great deal. South Asians, Indians in particular, have higher rates of alcoholism and obesity than other ANHPI communities. It's because we're using food and we're using drugs to treat our pain. So take care of your physical body, and your mind will follow. Get care when you need it. Ask for help. Number 3. 988 is there for you. Talk to your primary care doctor. Talk to a loved one. What's kind of paradoxical is that actually Indians have much more social connection than most ANHPI groups. Right? We are actually much closer to our families and to generations of our families than other even Asian Americans. But we don't actually have the conversations that we need to be having. So leverage those connections. We all need social connections, but ask for help when you need it. And lastly, and what I'm trying to do today, is tell our stories. Nobody wins. Nobody benefits when you hide. Nobody benefits when you pretend that you don't have issues or that our families don't have issues. Nobody benefits. You don't benefit, family doesn't benefit. And if there's one person out here that's listening to this that says, I can relate to that, then I've done my job. Then I've done my job. And I will keep doing this everywhere I go. I deal with a bunch of issues as health commissioner in New York City. We're just talking about things like measles and TB. And so I get to use the range of my public health training. And it's so much fun. I love doing this to help. But this is the most important work, because this brings my personal journey, my professional journey into alignment. And I can really see the impact that I'm having on people and on the next generation. And if there's a young brown kid looking at me saying, I get to talk about that now, then like I said, I've done my job. Thank you for listening. I hope that we can do better together. And I'm always here for the conversation. So please do reach out.